Restrictive pulmonary diseases are major risk factors of perioperative morbidity and mortality. The incidence of pulmonary complications may be in the range of 3 and 40% depending on the underlying disease and the type of surgery. So, let's talk about the definition. So, what is the definition of restrictive respiratory diseases? Actually, it is a heterogeneous group of disorders which is characterized by reduction in all the lung volumes, that is restriction, and decreased compliances on the pulmonary function test, but with preservation of expiratory flow. It is very important to note that the expiratory flow is preserved. Next, we are going to talk about the conditions that may cause such restriction. The intrinsic disorders like interstitial lung disease, also called as diffuse parenchymal lung disease. It causes diffuse inflammation and scarring of the lung tissue. Pneumonia is another cause. Tuberculosis, which is very common in India. Then sarcoidosis, idiopathic pulmonary fibrosis, interstitial lung disease, lung cancers, fibrosis caused by radiation, rheumatoid arthritis, infant and acute respiratory distress syndrome, inflammatory bowel disease in SLE. Extrinsic disorders, they are such anomalies of chest wall like kyphoscoliosis, or it could be an anomaly of pleura, for example effusion, trap lung, or abdomen. If there is ascites, if the patient is obese, morbid obesity, or there is any mass that mechanically compresses the lung or limit its expansion. Other extrinsic cause is pleural effusion, or the buildup of excessive fluid between the tissue layers surrounding the lung. Then there is scoliosis or twisting of the spine. Neuromuscular disease or condition such as multiple sclerosis and muscular dystrophy, obesity, myasthenia gravis or intermittent muscle weakness, malignant tumors, rib damage, especially fractures, ascites or abdominal swelling connected with liver scarring or cancer, diaphragmatic paralysis, kyphoscoliosis or hunching of the upper back, diaphragmatic hernia, and heart failure. Neuromuscular disorders affecting chest wall nerves and muscles to decrease the ability of the respiratory muscles to inflate and deflate the lungs. It results in chronically reduced lung volumes and restrictive physiology. Now, the test, we use tests to assess our patient. So, normally when the patient comes for PAC, then we assess for risk stratification, that how much the compliant lung is. So, number one is pulmonary function test. In patient with restrictive disease, they will show a reduction in total lung capacity, leading to reduction in both FEV1. FEV1 is the forced expiratory volume in 1 second, and there is reduction of forced vital capacity. Because both the value, that is FEV1 and FVC, both are reduced, the ratio of FEV1 and FVC remains normal. It remains normal in restrictive pulmonary disease. We are talking only about the restrictive diseases. So this is the graph which shows, it is plotted the parameters which are there, it is showing in the graph here. The graph, this is the graph of patient with normal pulmonary function. This is the graph. This is the slope of the graph in patient having obstructive pulmonary functions, and this is the green line, as you can see, is that of restrictive pulmonary function. So coming to the flow volume loop is in general normal, but demonstrate reduced lung volumes. As you can see, it demonstrates the reduced lung volumes, and FRC is decreased. Total pulmonary compliance is also reduced, and patient with restrictive disease increase their work of breathing by taking slow and deep breaths. Now coming to forced vital capacity test. It involves inhaling and filling the lungs with as much air as possible and then exhaling with as much force as possible. The FVC of those with restrictive lung disease is typically decreased. FVC value of less than or equal to 80% of what is expected can be a sign of restrictive disease. Now coming to forced expiratory volume in 1 second. It measures the amount of air exhaled during the first second of the FVC test. Most of the people expel about 3/4, that is 3/4 of the air inhaled during the initial phase of exhalation. In the restrictive disease, because the FVC is usually reduced, the FEV1 will be lower proportionately. Now coming to the ratio of FEV1 to FVC, which compares the amount of air expelled during the first second of the exhalation to the total amount of the air exhaled during an FVC test. This ratio is often normal or even increased in those with restrictive lung disease, and normal ratio is 0.7. Now coming to the preoperative assessment. Our aim is to identify the patient at high risk, that is, and it is used that the risk assessment to stratify perioperative management and focus resources on the high risk patient to improve their outcome. Now coming to the assessment of respiratory functions. When the patient comes to us for PAC, we take a detailed history, baseline spirometry is done, respiratory mechanics are kept in mind, lung parenchymal function is done, and cardiopulmonary interaction. cough test. Now coming to the bedside. Now the tests, the bedside tests are like cough test, wheeze test. They are performed by asking the patient to take a deep inspiration and cough once, and the test is positive if the first cough leads to recurrent coughing. Then we come to the wheeze test. Patient is asked to take 5 deep inspiration, and the patient is then auscultated between the shoulder blades to determine the presence and absence of wheezing. And the rest of the class will be conducted in next session, and you are requested to go through all these and draw the flow volume loop. Thank you so much.